Hello, welcome everyone. This is Mary Ann Mason. I'll be presenting first, but I think before that we're having a little housekeeping. Is that right?
Yes, welcome everyone. My name is Sarah, and I will be your tech specialist for the webinar today. We welcome any questions that you have. Please submit them in the chat, or you can use the Q&A tab at the bottom of your toolbar. So thank you so much for being here today. And what we'll do is we can get started with our presentation. Marianne, if you don't mind introducing yourself, give us a little bit of background, and then we look forward to your presentation.
Sure. Thank you, Sarah. And hello, everyone. Thank you for attending. My name is Mary Ann Mason, and I'm an associate professor of emergency medicine at Northwestern's Feinberg School of Medicine. And I'm also the associate director of the Buehler Center for Health Policy and Economics. I'm a sociologist by training, and I work primarily in the area of injury control, which encompasses a lot of different substantive topics, one of which I have been deeply involved in for the past 5 or 6 years is overdose prevention. And in particular, I have developed a interest in research portfolio around the older adult drug overdose experience. So today I'm going to kind of leverage that work, that prior work, and talk a little bit about older adults and unintentional drug overdose death in the United States. We'll look at some trends and really try to understand this group's experience. So please feel free to ask questions during the presentation as well. So a lot of people, when I initially present on this, asked me, well, why older adults? It doesn't seem like a population of concern for this, but in fact, it is a population of concern. But they're often overlooked when we talk and think about the overdose crisis. We mostly are thinking about younger people, but if we look at the data, which I'll show you in a few slides, you'll see that we're overlooking a substantial part of people who experience the overdose crisis. And there could be reasons, there are some unique reasons why older adults experiencing the overdose crisis deserve to be looked at more deeply. One is that they experience some unique risk factors that other age groups may not experience. One is because as we age, our body metabolizes substances differently. We're more sensitive to them. They can have negative effects of substance use at lower use levels. So they're particularly vulnerable just due to the fact of metabolic aging. And there's also more exposure to polypharmacy. As we age, most of us begin to take on medications for comorbidities. And so there's a lot of multiple substances being taken. And the consequences of overdose in older adults can be more severe than younger adults because of some of these comorbidities. For example, the presence of heart condition and overdose, the propensity for stroke related to overdose are higher for the older adult. So even if one survives an overdose, the consequences could be much more severe at an older age. And even if you're working to get on the other side of substance misuse, withdrawal and recovery can be tougher and complicated by the comorbidities and by aging. So the consequences in way back are more complicated for the older adult as well. So for me, these are all reasons why we need to focus on this group and help them get to the other side of this. So before I get into the data, I just want to disclose I have no conflicts of interest to declare. So this, I think, is a really interesting line graphs. So the blue line are people ages 15 to 54. The red or orange line, depending, people ages 55 plus. And you can see they kind of mirror one another through the many years of this measuring drug overdose deaths, right, from 1999 to 2023. But what's different and what's emergent here, I think, is a real concern, which is the 15 to 54 overdose rate has sloped downward a little from 2022 to 2023, while the older adults continue to rise. So the much heralded decrease in overdose deaths has not really impacted the older adult population, which means they are um, in some ways a unique group and a group of concern because whatever we're doing to abate or ameliorate drug overdose death doesn't seem to be having the positive effect it's having on other groups. And there could be a lot of reasons for that. I don't know that we know all of them, but it's an important group to consider. And here's another reason why I think it's important to look at this group is the exponential increase in overdose death rate in this group. They start out very low, like 1.3, a rate of 1.3 per 100,000. And by the time we get to 2023, it's over 30 per 100,000. That's like an 1,800% increase, which tells us we're not going in the right direction, and the magnitude of that is quite high. Um, Here's something that most of us wonder about, which is when these older adults are dying from an overdose, what substances are involved? Because knowing the substance involvement helps us develop effective interventions, treatments, recovery strategies. But what we'll see here is the green arrow or the green line has increased steeply from 2016 on, really. And that are other synthetic opioids. And there I'm going to say it's primarily fentanyl. So this population has increased, highly increased involvement of fentanyl in their overdoses. But you'll see something pretty interesting too, is the black line is stimulants, and see how it sort of weaves up with the green line and weaves through it. But there's a radical uptick in the involvement of stimulants in these older adult overdose deaths. So we're looking at both opioid and stimulant involvement, which is kind of a new game in terms of how do we prevent, how do we do harm reduction, how do we structure recovery for those populations. It's somewhat similar, I'm not showing the data here, it's somewhat similar to the trend going on with the younger adults as well. But older adults have certain exposures to stimulants that make them more at risk, primarily heart conditions, which makes stimulant use even more dangerous for them. So that is kind of the context in which we're dealing with the adults. And here you can see in this graph, you can see in the US, the percent of overdoses among older adults is increasing. In the other age groups, for the 15 to 24-year-olds, the percent of their contribution to overall overdose deaths has decreased over the years. Same for the 25 to 34-year-olds. But for the older adults, we see it going the other direction. They're increasingly more higher contributors to the overdose death problem in the United States, both in the 55 to 64-year-olds, which has a higher prevalence, but also the 65 plus year olds. So we actually see a kind of bifurcated trend going on in the US where older adults are sort of picking up the slack, and the younger adults are either plateauing or decreasing their prevalence and overdose rate. So, yet another reason to pay attention to this group that has not yet received a lot of attention. So, we do know a few things about older adults and overdose prevention, and they all point to this population being overlooked and underserved in terms of harm reduction, treatment, and recovery. Um, Older adults are less often screened than younger age groups for substance use disorder. They're less often offered medication assisted treatment, which is the most effective form of treatment for overdose or opioid use disorder. They're less often reached by harm reduction services, and there's some reasons for that, but they have less exposure to the prevention and treatment there. But then also, when the older adult makes it into treatment, they face additional burdens, things having to do with age, like mobility limitations, hearing, eyesight limitations, and comorbid conditions that can make treatment and recovery more difficult. Um, and then there's some work suggesting that stigma may be a bigger preventer of getting services and getting into treatment for older adults than it might be for younger adults. There may be some sort of cultural things associated generally generationally with this group, including having lived through the height of the HIV crisis, where intravenous drug use was associated with HIV and the negativity of that. So, kind of wanting to be under the radar and not getting involved in needle use outreach and things like that, which is the primary vector for harm reduction services in a lot of communities. Also, this is a community that may have started when they were a user, went through a period of being clean or abstaining, and then have begun again. And they really don't want to admit that in a public environment where they would seek help. And then again, this is a group that generationally went through the worst of the war on drugs, at least in the United States, and they have really negative perceptions of drug use and the labeling that went along with that. And again, there's shame and stigma with identifying as a drug user so you can get help. So these things can keep the older adult population away from treatment and away from things that can be helpful to their health and well being. So there's an unmet need here, in particular for older adults. We need these screening that reflects the stage of life that people are in. Lots of screening asks about can you meet your job or family obligations? Well, a lot of older adults don't have those anymore, so the screening may miss things going on with them. We need supports integrated into treatment and harm reduction and recovery that can deal with the physical limitations and challenges of aging. Um, the things that are offered need to be offered in contexts where older adults are already seeking and receiving assistance in order to catch them, in part because of the stigma going on with them. And whatever is done has to address the morbidities in this age group, and there are many for people who use substances. So these things are all needed; they're unmet needs, and we just need more of that. So we do know that interventions specifically for older people are not common. I've looked through the literature every few months on this, and I think in my entire time looking, I've seen two or three that were especially designed to meet the needs of the older adult. And there have been studies that really show that the most successful way to do this is to align with other areas of health and well-being. So primary care is a good one, or specialties commonly seen by the older adults. And then delivery in locations where people are already going, so they're not making another trip or having to find extra transportation. Those things can really help develop interventions for this group. So I'll just say my next steps as a researcher is trying to find opportunities to develop focused interventions for this group and then test the implementation of them and outcomes of them so that more older adults are engaged and more positive outcomes can be had, and we can reverse the trends that are currently going on now in the United States. So I can take questions now or wait. I guess it's up to Sarah, who's moderating our panel.
Hi, Marianne. I'm Lois Herman with WUNRN, the Women's UN Report Network. I'm wondering how insurance, Medicare, and Medicaid addresses older adult usage.
Actually, with Medicaid expansion, Medicare and Medicaid expansion, and the Medicare now covering treatment, it's kind of a nice spot for the older adult. They're covered, whereas maybe when they were younger, they wouldn't be. So it actually is an opportunity for intervention.
Thank you.
Mhm.
Sarah,
All right.
do we have any
Yes.
questions here that we should bring up, or we'll move on to Dr. Lori?
Yes, I think what we can do is we'll have some time a little bit later for some questions. So, Marianne, thank you so much. I'm going to go ahead
It's a
and we're
very
going to
insightful
shift.
presentation on a
Yes,
population segment that is not addressed adequately in drug attention. Yeah, thank you. Now,
yes,
Lori, hello.
yes, and thank you.
Will you
Hi.
turn off? There you go. Dr. Lori Post, we've known for years. We've worked on a number of women-centric and population-centric issues. And by the way, Marianne, I would really be interested in gender disaggregation of some of that data. But Dr. Lori, you are next to speak to us and offer words of wisdom.
Great. Can you see my screen?
Yep.
Okay. All right. So I'm going to a little bit of repeat of what the great Marianne Mason just talked about. That was a fabulous presentation. Thanks, Marianne. So I'm going to talk today about, wow, congratulations. We have a deceleration in drug overdose deaths. We've been going up for 2.5 decades. However, I want to give a cautionary tale is that not everybody was invited to the victory party. And so that's what I'm going to talk about. And I'm going to disaggregate about like who are the winners and losers of the big decrease in drug overdose deaths and what are some of the problems that we have with it. Okay, first of all, the background about drug overdose deaths. And as I just said, that we have had an escalation basically for 2.5 straight decades. And over that time period, some of the growth has been linear. Sometimes it becomes exponential. And then what we don't want to do is conflate a deceleration or a period of extended decreases with plateaus. And so my most recent research, I'm working specifically on coming up with the different segments and differentiating linear growth from exponential, from plateauing, from true deceleration. And then I wanted to also throw out there that the problem with surveillance on drug overdose deaths is it's super dated. So right now, this morning they just dropped data for October of 2024, and we're already sitting in March of 2025. And just think about this: if we, I love to give this comparison. If it was listeria, if only drug overdose deaths was listeria, it would be amazing what we could do. And that would be like active surveillance. Right now, they're very passive. It takes time for, so much time for someone to die, to be captured at the local level, reported to the state level, reported to the federal government, and captured in data systems there. However, like if this was listeria, it would take about 2 days of people getting the symptoms for listeria and death from listeria. And investigators from the CDC would have already gone out. They would have found out where those people had their food at, how they got exposed to listeria. They would have found out what grocery store, they would have found out the product line, they would have found out who shipped it to that particular store and what was the origins or the source of them, who manufactured a particular product that gave them listeria. And they would have that licked in about less than 1 week, right? And we don't have that many listeria deaths. It's just a handful of them every year. In contrast, drug overdose deaths, we're talking about hundreds of thousands of deaths that have happened in the last 25 years, and it takes us months and months. So if we were to look at the annual count of drug overdose deaths, we only can go up through 2023. And if you look at it from that perspective, 2023 is the highest year over that whole entire time frame of when we had drug overdose deaths. But the reality is that somewhere in the middle there, something happened, and it wouldn't really be picked up in surveillance systems unless we go forward or look at drug overdose deaths another way. And so to that end, instead of looking at annual overdose deaths, which they're beneficial, however, they're not so helpful in emergent trends here. And so I would only be able to go up as far as, whoops, sorry about that. I would only be able to go up as far as 2023 as a whole calendar year if we're looking for complete years. However, I'm doing something a little bit different, and that is I'm taking data from the National Vital Statistics System, which tracks all deaths that come from death certificates that are aggregated to the state, are aggregated to the nation, and I'm looking at a 12-month moving sum. And why do we want to do a 12-month moving sum? And that's because it's really noisy data. And that means that we have natural, ups and downs every month. They can be related to supply, demand, a lot of reasons what they're related to. Also that death in general is never randomly distributed across the year. You tend to get, increases in drug overdose deaths in particular at the end of the year and in the spring. And so it's hard to really tell when are drug overdose deaths decelerating and when are we plateauing, and what is just noise and what's really the signal through the noise or the forest for the trees. And that's what this model here does. And so I have 12-month moving sums by in the calendar year of the drug overdose death rates, and I'm also using a type of interrupted time series analysis called joint point analysis. And that means I test for different intercepts. And if you look at my top line here in gray, that is all drug overdose deaths. And what that tells us is that from here, I'm going from just January of 2015, and I'm doing a 12-month moving sum. I come up to, we have growth. We're actually in exponential growth up until September 7th of 2017, and then we get a shift and we end up with a plateau. And the plateau goes clear straight through October of 2019, and then we move into exponential growth again. And then by April of 2021, we shift from exponential into linear growth. That tops at February of 2022. And then we see again another big plateau until January of 2024. And then at that point, we start to see a deceleration straight downwards. And there's different ways that we can measure this. This is just a first analysis, and now I have a few months more of data. Some of this will change slightly, but you get the general pattern there. And then if you look underneath my gray line there, I have the red line, which is opioids. Opioids are the primary driver of drug overdose deaths. And for all the bad things that stimulants do to people, it's still opioids that are the primary drivers. And of course, recently, this here data begins in 2015. This is mostly fentanyl. And so you see that the pattern of the red line is very similar to the gray line, and that is because opioids are involved in almost all drug overdose deaths, except for approximately about 25%, depending on what year, what time, what place. All right, then you see below is I also have plotted out here cocaine and methamphetamine. And so originally in 2015, January of 2015, we have cocaine drug overdose deaths, and those are slightly higher, but they're relatively quite small to opioids. And then we also have methamphetamine, and then you see somewhere around 2020 they cross over, and methamphetamines become more prevalent in term for underlying cause of death than for cocaine. There are other types of drug overdose deaths too, could be like sleeping pills, benzodiazepines, but I just plotted out here the 4 major ones. And also, I also want to qualify this as I'm looking at the underlying cause of death. This is one way to look at the death, and this is the National Vital Statistics System. They include all deaths that happen within the United States, as opposed to some of the other metrics that we see that are only involve U.S. residents, and I chose to go with this one just because of the how emergent it is and how important it is to have the last 12 months over time to get updated information. So if you look at this figure here, we have the 12-month moving sum drug overdose death rate ranged from 15.1 on January 2015 to 28.8 in June of 2024, with the highest rate of 33.9 recorded on August 2023. And then between January 2015 and September 2017, drug overdose deaths significantly increased by 0.22 persons per month per 100,000 population. That plateaued on September 2017. I'm not going to get into all the little nuances of it, but not only are drug overdose deaths decelerating now, but the rate in this last leg that I show you there, that rate is deeper, larger. It's exponential deceleration for the first time. But this is not true for stimulant-related deaths that include both fentanyl and methamphetamines. In particular, and I'll get to that here in a minute. But basically, opioids are decelerating 4.6 times faster than cocaine, 2.9 times faster than methamphetamines, or 1.77 times faster than if we combine methamphetamines and stimulants and cocaine together. So I'm going to move on to my next slide. Now here I'm using a different data source. This one here is it's the same data source. However, I'm looking at it just in terms of an annual, because I don't have the complete year for 2024, so I just want to go up through 2021, but I'm comparing US regions. Again, these are all drug overdose death rates, and so this figure here illustrates the differences in overdose death rates across the US census regions by the year. So we have the national, which is the dotted line there, the green, which is the Midwest, the brown is the Northeast, purple is the South, and red is the West. This is a really important thing to look at, and that's because the United States is not this homogeneous population, and it is not the same depending on where you live at. Deaths come at different times, and what we think is that fentanyl in particular did not make its way out to the West Coast until very late in the game. They were more likely to have heroin, and heroin is way less lethal than fentanyl is. But as you can see here at the very beginning, we see that the Northeast, brown, they had the highest rate of drug overdose deaths in 2015, and the West Coast, which California makes up a lot of that population, had the very lowest rate. And then over the course of the years, we see that there was a switch over in 2021 where the Northeast starts to drop down. The US national average is going up. The South has higher rates, dragging the mean up. And then we see the Midwest is coming down. But the most importantly, we see the West Coast with the heavy population increasing. So again, it's super important to note that drug overdose deaths are decreasing in general. However, not everybody is enjoying some attenuation of the crisis, of the drug crisis. So, and then I would say this here, my data here end in the middle of 2023, and since this time frame, there still are 3 states that continue to accelerate, and that is the states of Nevada, Utah, and Alaska. Those data were just dropped today, so that means that they're not experiencing a deceleration at all. They're still dragging their region up. And this is very important too. And we need to think about drugs in the same way we think about the spread of disease. It moves from one region to another. When you think you've got one problem resolved, so for example, we had prescription opioids in the early 2000s, and those were replaced. Those gave way to heroin primarily, which gave way to fentanyl. And every time we would solve or get traction or make progress on one, we would have an outbreak of another. And anyways, and it travels, it's dynamic, and it does not affect the whole United States at the same time. It's important to note who is not part of the deceleration. Okay, now Lois had asked a question about, I'd like to see that by age. And so my final slide here, I have that table one. This table here compares the US drug overdose death rates by demographic characteristics. So each cell is color coded according to the rate change compared to the prior year. And so that means the really red means you're increasing quite a bit, and the dark blue means you have the best benefit. And so up here we can see, so let's start off at a national level. We saw, you see whenever it's turning red, darker red, from going from 2015 to 2023, we had attenuation in 2018. We had a plateau between 2018 and pretty much 2019. Then we start seeing quite a bit of significant increase that corresponds with the pandemic setting in the year 2020 and 2021, a little bit better. 2022, we have there's an increase, but not much at all. And then we see a decrease by 2023. So a national improvement where the death rate is 33.71. This is still a horribly outrageous, unacceptable rate because these are preventable deaths. If we want to look at this by male and female, so they kind of mirror each other here. However, males had a worse outbreak during the pandemic. They started before the females in 2019, then it gets worse in 2020. And their rate is for males is 48.05 in 2021, and that rate is half of it for females. The gap between males and females decreased, but then in 2022, we see a slight decrease for females, a slight increase for males. So you still see it slightly red. But then by 2023, we have an improvement for both females and males, but males are now about two and a half times, almost 2.5 times more than they are for females in terms of drug overdose deaths. Now we look at the age groups over time, and you can see here the really dark reds, as you can see in 2020, those completely correspond to the pandemic. But we don't want to just attribute drug overdose deaths during the pandemic because of the pandemic, because there was already an acceleration going on that began way before the pandemic hit. So in 2019, we already saw a reverse course. We already were increasing. Polysubstance was already a thing. And we saw for especially 35 to 44-year-olds, quite an increase that happened in 2019, way before the pandemic. And then also remember that pandemic didn't really come to America until April, May, June, depending on what state you were in, and the shutdown happened then. We were already on our way up by the time this acceleration was happening. So I just want to make it really clear that definitely it's probably exacerbated by the pandemic, but we were already experiencing polysubstance, meaning stimulants plus opioids. We were already increasing, and then that increase only accelerated during the pandemic. And then we see for older adults, what Marianne was talking about, here we are 2023, older adults still have an increase going on. So they moved from, if you look across the pandemic, they went from 20.25 in 2019 to 23.97 to 29.17 to 30.74 and to 32.24. They're increasing. Everybody else is coming down, the older adults. And the best improvement happened between 25 to 34-year-olds, where they were quite high in 2020, but then they were still high in 2021, but that rate of increase was slowing down. But then we see a nice decrease that happened in 2022, and then and even further in 2023, where you see the darkest blue spot on the whole demographics. And then I want to look at this by ethnicity. If we look at Hispanic or Latino versus non-Hispanic and Latino, we see that at the very beginning, if we were to go back to 1999, you almost see nothing going on with Latino populations. However, it's increasing since 2015, up. We're not seeing it, and we're not seeing an improvement. That there's still an increase going on this whole time in the last full year of data that we have. Latinos are at 23.83. That's still below the national average, but they're still increasing. And we see a significant improvement for whites or non, how about, I don't want to say whites, it would be non-Hispanic, because of course some Hispanics are Black or Asian even. So we see an improvement for non-Latinos. It improved, it was worse during the pandemic or 2020, 2021. However, it reversed course and now we have improvement. That is not shared by Latinos. Now we go down into racial categories here. This one here, because the U.S. Census Bureau changed how they measured race, it's hard to crosswalk that before 2018. And so you can see I have NA there for the years before then. But what I can tell you about since 2018, just because we add on additional racial categories, and some people who were once self-identified as Black or African American may now identify as more than one race. Same with other racial categories. And so if we're looking just from now 2018 to 2019, we see that it's getting worse for American Indian or Alaskan Natives. It's getting worse for Blacks and African Americans the rate is 26.66. Again, if we were to look back at 1999 for African Americans and for Native Americans, that rate was so small relative to whites. And all we see is increases. So no improvement. The rate of increase is slowing down, but no improvement. So we see that by the year 2023 for Native American Alaskan Natives, it's 43.42 for American Indian Alaskan Natives. And for Black or African Americans, that rate is 52.1. It's also has increased to 24.67 for Native Hawaiian and other Pacific Islanders, where compared to whites have only improved since 2020, and that rate is down to 33.21. So that's a significant difference between Native Americans and to African Americans. And again, I'm trying just to point out here is this table here is I'm looking at not only do we have improvement or are the rates getting worse every year, but the color tells us how fast the rate is changing per year. So then I want to just talk about, what this means. And that is that these findings suggest that while drug overdose deaths are, they're definitely decelerating at a national rate. Nationally, the decline is not uniform across regions, demographic groups, or substance types. So although the overall decrease is encouraging, disparities persist among the West region, in particular, Nevada, Alaska, and Utah. Older adults are not doing well. They continue to increase. Latinos, Blacks, African Americans are still increasing. Native Americans, Alaskan Natives, and are still increasing, and so are multiracial populations. The West had lower drug overdose deaths in 2015, likely due to fentanyl's later introduction compared to other regions. However, these states may be experiencing a delayed onset compared to the Midwest and Northeast. By 2023, the acceleration observed earlier in other regions reached the West. And again, it looks more like a disease, the spread of a disease, and we should think of that as likely related to supply, basically what's available. And so one possible explanation for national deceleration is a cohort effect. A cohort effect would be basically after mass death, it is possible that immediately in the immediate aftermath without new initiators of drugs is that those people at highest risk for death have already died and therefore they're no longer at risk to die a second time. Cohort effects also, we can look at people who are dependent for perhaps on heroin or on semi-synthetics. When those supplies are cut off, they may switch to something more volatile. So basically people with dependencies don't go away. They just switch to a new drug and that becomes more lethal to them because it basically fentanyl, some fentanyls are 100 times more potent than heroin or morphine. Then there's carfentanil, which is more potent than fentanyl. And then also a cohort effect is people can live for years with substance dependencies, and then as they age, their bodies metabolize differently. They're less resilient to substance use and may be more susceptible to death. That may explain some of the differences in deaths as people age. Anyways, and so the cohort effect, if you think of it as mass death, this is very consistent with what we found. We're following every exponential growth. We ended up with a plateau and then finally a deceleration. Since 2023, in 2018, we had mass growth between 2014 and 2018 with the onset of fentanyl. That was followed by a plateau and then a deceleration. The most recent acceleration predates the pandemic's onset, but intensified during the quarantines and attenuated as the U.S. returned to work and school. Then also possible explanations for the national decrease in drug overdose deaths include possible fentanyl negative supply shock, harm reduction strategies. There's expanded naloxone distributions. And then also some people believe that the adulterated drug supplies, meaning the addition of things like animal tranquilizer, may have a protective factor because as bad as they are, they're not as volatile as the fentanyl or carfentanil. And examples of that are like xylazine, ketamine. Anyways, but in some we have opioid deaths are decelerating faster than stimulant deaths, and at a national level, it's better, it's promising. But I think I just want to end my talk today with it is as important to understand why drug overdose deaths are going down, because they will certainly reverse course. And there's always something worse that comes out. There's always derivatives. There's new powerful combinations, new trends. There's always dangerous supplies. We don't really know what caused it. We don't know. We can understand the increases sometimes are related to supply. However, those supplies are still out there. So why is it that they're coming down? And again, some harm reduction, the ones I didn't talk about already, might be the mode of ingestion. For example, there's some evidence that smoking fentanyl is less volatile than injecting, snorting, or swallowing. And with that, I'm going to stop my presentation and happy to answer any questions, or I'll wait till the end to answer any questions.
Lori, thank you so much. People are always saying, where's the data? In order to get funding or get support, where's the data? And you have, even though there's always a need for more. I'm curious about with refugee, immigrant, displaced populations, they are very hard to track. And has any work ever been done on that?
Yes, and let me just explain that there's I believe Marianne used the WUNRN drug overdose death, and I believe Spencer's also going to use the WUNRN data. The CDC uses WUNRN wide accessing online drug, or not drug, death. I don't remember records. I think that's what it stands for, and that they exclude all non-US residents. But the NVSS includes US, non-US resident. That would be undocumented persons or persons without permanent residency in America. So there's a few hundred of those every year. So I can't speak off the cuff right now because I'd have to subtract out the WUNRN data from it. They're both great data sources. They have pros and cons to each one. But if you look at NVSS over the WUNRN, it does include non-US residents. And also, let me just say, it's really hard to track substance use disorders at a national level. It would be very hard to track people who are undocumented, just sort of like the US Census can't pick people up who want to not be picked up. So people who want to remain invisible, like undocumented migrants, or recent migrants that don't have U.S. resident status yet. However, it's hard to hide a body. So deaths are always one of the best proxies for any what's going on with a drug, a pandemic with a drug, or any type of issue whatsoever. Because when you have a death, we have to resolve the death or take care of the death, and those are entered into systems. Those are addressed by the state medical examiners.
Mm-hmm.
Public health
Thank
department.
you. Another subset that would draw attention over time would be the increase in homeless people in the United States and other countries such as UK.
Yep.
Lori, would you like to introduce our next speaker? We have two gentlemen who have words of wisdom for our audience.
Yeah, I'll be very happy to introduce Dr. George J. Unick. Jay goes by Jay, and Jay is going to. I'll let him speak. Jay is my colleague. We work together. He's from University of Maryland at Baltimore, and I will surrender the microphone to Dr. Unick. Thank you.
Thank you, Lori. All right, I'm just going to share my screen for my slides. So I have a little bit more of an optimistic conversation to have with y'all around recovery-oriented systems of care. We know that substances, particularly in their problematic use, really drive a set of problem-oriented problem behaviors, things like engagement with the criminal justice system, health consequences. Lori talked about overdoses. Marianne hit on that as well. This gets particularly challenging when folks enter their older age years and drugs have higher risk profiles. They interact with comorbidities. So when individuals have been using for an extended period of time and have problem use, a whole bunch of issues happen with them in terms of their connection to social institutions, whether that's jobs or families or churches or any other kinds of social institution that we consider a positive social interaction. And people develop a whole host of relationships that form their support network, but are often integrated with drug use themselves. And so when we want people to stop using drugs or to decrease the use of drugs, we need to engage in recovery-oriented systems of care that can help them transition their life to another to build a foundation of social support and social interaction. Some of this, and we just talked, Lois just asked about homelessness being a really important piece of that. If you don't have a house, it's hard to be very positive about your future. Drugs have a little bit more of a, they have more of a hold on you if the alternative is sleeping on the street. And so these recovery systems of care really need to touch on a number of areas. So substance use is problematic for a lot of reasons. It's not just about the personal medical piece. It's not just about health consequences in the form of mortality, overdoses, or other forms of morbidities. And we also know that in terms of how people get the problematic use, that's not just an individual genetic or personal characteristic. It's often linked to other social factors. We know that trauma histories, Lois mentioned refugees, people that have had a lot of traumatic experiences are at much higher risk. Family history, if we've grown up in a family that misused substances or used substances in a way that's potentially harmful, those are really strong mechanisms promoting high risk behavior. And then there's also environments. We know that for young people, the biggest single risk for any young person developing a substance use problem is having peers that also have substance use problems. So these are fundamentally social issues. And while there is evidence that a lot of drug use behavior is linked to genetics. So for example, if you don't process alcohol well and you have a drink and it makes you sick, you're less likely to have an alcohol use disorder. But if you can process that alcohol really efficiently, then the positive effect of that short-term intoxication outweighs the longer-term negative consequence of the toxic alcohol effect. And so there is a personal genetic risk, but it is really embedded in these larger social systems. And so at the individual risk level, it's this interaction of person and environment. The other piece that's really important to talk about, and Marianne hit on this as well, is the idea of stigma. Because when we want people to move from a system of using drugs to either engaging with harm reduction services or engaging with treatment services, they need to first identify as somebody that has a problem that needs to be addressed. They have a high level of harm or risk that they want to minimize, that's harm reduction, or they want to enter some form of treatment. And so excuse me. And so stigma has a very strong effect on the willingness of individuals to accept that about themselves and to move into some form of treatment. It affects treatment outcome, and it also importantly affects treatment availability. Globally, treatment availability for substance use is much lower than for other high consequence disorders. It's much easier to get treatment for heart disease or for even HIV these days than for substance use related disorders because of stigma related concerns. So the availability of treatment by systems, health systems itself, is really linked to these concepts of stigma. When we think about the sort of the evidence for addiction, a lot of those studies come from rats. I was just at a presentation right before this with somebody that does this kind of research. And if you look at these cages and think about what's happening socially for these rats, you can imagine that these are not very highly interactive facilities. These are not places where rats have a lot of social engagement. These are places where rats are isolated and are probably traumatized. Not being a rat myself, I don't know this for certain, but I would guess if I lived in a box where I might be able to see, but I couldn't smell, hear, touch, feel, interact with another creature, that I would be very, very distressed. And so we put these creatures in these high level of distress environments, and then we offer them a drug that alleviates some of that distress. And then we say, aha, see, exposure to drugs creates this condition, when we ignore the fact that these rats are in particular social settings that drive that. So a lot of our understanding of addiction, which comes from these rat studies, is really about the social conditions of the rats. And we know that because there's been a whole bunch of studies that look at alternatives for rats besides those cages. And the most famous of these is called the Rat Park study. And what they found is that if you offer rats an enriching environment, they don't want to sit around and get intoxicated all day. They have other things that they would really rather engage in. They would rather play. They would rather have intimate relations. They would rather smell. They would rather engage with their environment than just sit and press a button and administer cocaine or morphine or some other substance. And so what this tells us in very concrete research terms is that the environment matters. The context in which we live determine what our risks for substance use are and what a problematic risk behavior is, but also how we can develop systems of recovery for individuals to help them move from places of harmful substance use to places of less harmful substance use. The good news for opiates, and both Marianne and Lori shared a lot of the bad news with opiates. The good news with opiates is that for a lot of the biological problem, the craving to reuse opiates, the innate biological addiction, that disruption of our dopamine reward systems that teach us to engage in certain forms of behavior, can be medicated. We have a very effective treatments for opiate use disorder. In the United States, we have methadone, buprenorphine, naltrexone. If you're in other countries, I know in Switzerland, they have 9 different options. Canada has multiple options. There's a lot of different forms of treatment that enable us to address the underlying biological craving that happens with addictions. When taken as prescribed, these medications are effective. They're as effective as treatments for any other chronic disease. Diabetes is sort of the classic example, but heart disease would be another example. When individuals are engaged in systems of care that have them and that allow them to access these medications and provide convenient mechanisms for maintaining use of these medications, the treatment outcomes are very positive. And so that is a big, important take-home message. There is hope. We can do things. We have effective pharmacological treatments for opiate use disorder. Of course, the problem is that only 7.5% of individuals in the United States with an opiate use disorder have access to these drugs or are using these drugs on a regular basis or using these treatments on a regular basis. So few individuals with opiate use disorders have sustained medication-based recovery, which is the most important evidence-based intervention we have. This is not a problem of medications. It's not a problem of access to medications in many respects. In the United States, we've addressed a lot of the barriers to buprenorphine. In particular, methadone still has some access issues. But buprenorphine is widely available. Expansion of access to buprenorphine happened in the last 3 or 4 years in the United States with a series of government policies. And yet we still have an extraordinary underuse of these medications, which leads to the question, why? Well, I think when we think about where we want people to be and how we want to develop systems that can promote healthy living, reintegration with society, addressing the harms of substances, it's not about the medication per se. Medication is a necessity, but it is not the only thing that we have to have. There are other things that we have to have in order to have a treatment system or a system of care that is recovery oriented. The first one is health. So we need to have opportunities to have people take these medications. They have to be able to adhere to these medications. So that's a variety of adherence support. So you can't put up a bunch of barriers to getting access to those medications. And those barriers could be financial, right? So that's making sure people have insurance or some means of obtaining the medications. And then with Marianne talking about older folks, I think a lot of what we need to also be thinking about in terms of health is comorbid conditions. One of the things that, particularly with older folks, that drives use of opiates is pain. So if you're somebody that has an untreated pain disorder, if you have a condition that causes you to be in pain a lot, you're going to be at higher risk for misusing opiates just because you want to deal with your pain. And so managing a variety of health conditions and making sure our systems of care address the whole person's health is very important. And this includes mental health. So a lot of the mechanisms by which people become addicted to drugs is related to trauma and depression and anxiety. And so addressing those issues in a coordinated care system that recognizes that substance use is part of the package, I think is really important. In the United States, we have a hard time providing safe, adequate housing for affordable housing for our population. And that is an essential component of any system of recovery. A lot of what we do when we try to build systems of recovery is to embed housing as one of the options. So there are facilities called recovery homes that take people in that have a substance use issue, that are on their recovery journey. And so there's some specialty organizations, but you can also think about the cause of homelessness or the homelessness itself as a cause of escalating substance use. So even if somebody doesn't start off as having a substance use problem, if economic forces drive them into homelessness, that itself is traumatizing, leading and puts you into a street-based environment where there's lots of people using drugs, and that gets us back to the social context in which we live. So housing is a treatment option, but it is also a causal mechanism of driving unsafe drug use behavior. And so systems of recovery have to take into consideration the full spectrum of housing, from housing for safe, affordable housing for the general population that lowers the risk of homelessness, all the way to specialty housing that provides treatment opportunities for individuals engaging in recovery, where they can have a safe home in order to have that recovery journey be reasonably effective. People need purpose. And we often think of, most of us engage in some form of social activity related to our jobs, our schools, family responsibilities, creative activities. We really find value, many of us find value in those activities. And for people that have had a career using substances, often they've become disconnected from employment, they've dropped out of school, they've lost connection with their families. And so in building recovery-oriented systems, building those linkages back to those social institutions is necessary. It's not that hard to engage in detox. Lots of people can detox. We have medication-approved detox procedures, so we can help make detox relatively painless. We can get people through that initial detoxification in terms of the reduction of opiates in the system. We can engage them in medication-based treatment, but if we can't link them to jobs or schools or relink them with their families or have them engage in some meaningful activity, their recovery journey is going to be short-lived in most cases. And so it's really important for us to develop systems of care that take that whole person into account. And then, of course, the thing that sort of underlies all of this is some sense of community, of belonging to a social network that can provide support, love, friendship, and primarily hope. one of the things that's really difficult in recovery work, and if you like I said, I was just at this meeting where we were talking to some folks building rat models for recovery. And one of the things that I always challenge them with in talking about that is that first several months of your recovery journey is often the most painful. You have to reduce your reliance on your social networks that you've been reliant on for years, because those networks involve a lot of drug use. And as a clinician, as somebody that works with people, I see this all the time. There's this bias like, oh, we saved you from that toxic environment. But for a lot of people, that was the best set of relationships they've ever had. And the drugs ended up causing problems for them in the end. And the substance use of that community was problematic. But the community itself can often be very supporting. It can be a place where they receive non-judgmental love and friendship for the first time in their life. And so detaching from that community requires you to build another community that's equally supportive. And so when we think about what we need to do to build recovery-oriented systems of care, we need to develop systems that are focused on health, address pain, address mental health problems, and provide access to medications, give you a safe place to live, provide some form of purpose, social engagement and activity, and rebuild your community. So we have techniques for doing all of these things, and we call those recovery support services. There's a bunch of them. I can't go through all of them. I'm going to go through a few here to show you how we address each of those. So for example, with health, we have peer treatment navigators, which are individuals that have gone through recovery themselves, that have the experience of overcoming substance use, and they are linked to a variety of treatment systems. So for example, primary care. Many people neglect primary care while they're using. So getting somebody hooked up with primary care to address issues like diabetes or heart disease, to address underlying pain issues, to link them to mental health care. Somebody that can help you figure out how to navigate these systems. If you live in the United States, you probably are aware that we spend a lot of time trying to navigate health systems. We don't have the best form of integration. So having somebody that knows what it's like to be in your circumstance, help you navigate these systems and reduce the barriers to accessing health-related services is really important. I mentioned recovery housing as an opportunity to engage people in supportive living environments that support recovery, provide access to medications, or at least facilitate access to medications, provide you with a welcoming community, a safe place where you can live. We also have a variety of different purposes that we can drive people towards. So for example, in the United States, we have recovery high schools that are specifically designed for youth in recovery, or recovery-friendly workplaces. So there's a variety of things workplaces can do to provide support for workers that are also in recovery. So for example, instead of having a let's go out and drink after work kind of activity, have a more pro-social activity that doesn't involve alcohol. And so recovery-friendly workplaces provide a variety of opportunities for people in recovery to actively participate in the workplace, and also provide supports for various recovery-oriented services and activities that individuals do. On the community level, it is about building communities around recovery. In the United States, we have Alcoholics Anonymous and Narcotics Anonymous, which are sort of the most famous version of these. But there's a whole host of other recovery-oriented community centers. I work with a number of these kinds of programs here in Maryland that provide a range of support, from support groups to opportunities to volunteer, to access to peers that can do a lot of these things. They can provide you linkages to recovery-friendly workplaces or linkages to recovery housing. So they can do a lot of things to build out your larger area of social support. And then eventually some of those people become your friends. And it's not necessarily linked to the recovery community, but it is individuals in recovery that can help you along your journey. In the United States, we've really decided to invest a lot in what we call peer recovery support services. And these folks cut across all of these different service arrays. These are services provided by people that have had a substance use disorder in the past, and they're in remission on their own, and they can use their experience and their knowledge of how they navigated these treatment systems to help individuals. And the idea here is that that experience that they had gives them some in with individuals that are younger in their recovery journey. So it's a mentoring program, if you will, for moving people through the process of recovery. And a lot of it can be instrumental supports, helping you link to healthcare, helping engage you with transportation if you need to get to the doctor, pointing out where you can go get recovery services, or linked to recovery housing. But a lot of it is just having an ear to have somebody listen to you, to understand what you're going through, because that person has gone through it too, and to be able to see what the outcome could potentially be. And so these peers really have an opportunity to engage people outside the traditional clinical practice. So you would have your prescriber, your nurse practitioner, your psychiatrist that would prescribe the medications, but there would be an adjunct peer that can help you navigate the complexity of that recovery journey, because they've done that themselves. They've been there. The recovery housing settings, as I've talked about before, are these non-medical settings that are designed to support somebody's recovery by providing a substance-free living environment, and they're commonly used to help individuals in that initial transition. So once you get through detox and you're beginning your recovery journey, these are supportive environments that take a lot of the stress off of you in terms of housing, having to navigate rents and leases and things like that, and provide you with a brief period of time where you can just focus on your recovery journey in a supportive environment, and then in the optimal cases can then link you to other housing programs that can help you have sustainable market rates or traditional forms of housing. And so they provide this bridge between using substances, entering treatment, to a more stable long-term housing situation. We also have various forms of supportive employment. These are mechanisms by which we engage with individuals and employers simultaneously, and to link individuals with employers that recognize the challenges faced by somebody with a substance use history. Some of these things might involve traditional job supports like job skills, addressing childcare or lack of transportation. Helping address criminal history is a big one. So a lot of people that have substance use histories have minor crimes, shoplifting and things like that on their record that would be a barrier to employment. So a lot of what we can do is remove some of these barriers to employment and then provide people with resume support or childcare or other things that can help reduce the barriers to employment, and then also work with employers in understanding what they need to do to support somebody's recovery. And in environments where you have a constrained set of employees, like when you're an employer trying to hire somebody and there's not that many people applying for your jobs, these are often opportunities to engage with employers and open up a new range of individuals that can work with your enterprises. And in Maryland, we have a number of these kind of efforts to address these things through recovery-oriented community workplaces. And then there's recovery-oriented community centers, and they are often centers that do a number of these things. They will often do things like link you to housing or have even housing as part of them, or they have groups, support groups, and other things like that. But they really offer a place, a central place that you can go to receive the support, whether it's peer support or whether it's support groups that can help you along the recovery journey, and they provide a whole host of mechanisms. So some of the ones that I work with, like if you call them, they'll come and they'll pick you up. If you need to go to the doctor, they'll take you to the doctor, right? So a lot of this instrumental support that you lose when you lose your peer group, your friendship group that is still using drugs, the recovery centers can provide that as a bridge until you can build another one yourself. Often these recovery centers form the foundation of that subsequent recovery-oriented community. So all of these things are linked together in a recovery support system of care that includes mechanisms for helping individuals reduce their substance use through either harm reduction approaches, access to medications, or treatments, psychosocial treatments, contingency management, or motivational interviewing. So those are sort of the things that get you to reduce your use of substances. But building somebody's life back requires this whole host of other recovery-oriented services, and they are often a neglected piece, but an essential one to address the underlying mechanisms that drive people to use substances, and also provide a mechanism for supporting individuals along their journey. In order to really make this work, we have to build systems that allow these, in the United States, for example, expanding Medicaid options to pay for some of these services is really important. If somebody can't get housing, they can't build their community back. And so building these recovery-oriented systems of care require us to think along this continuum from treatment to detoxification to initial recovery orientation to long-term recovery. I will stop there and let us move on to the next speaker. And I'm happy to answer questions.
Thank you so much. I wish all the resources and ideas that have been presented today could reach a larger audience. And we will be, as Sarah noted, be video this panel. But still, there's a lot more communication, and we are reaching an international audience. One point I would like to mention is the source of the drugs on a non-pharmaceutical level. The profit is enormous. The three largest illegal sources of profit in the United States and international, that's from the UN Office of Drugs and Crime. One is drugs, another is arms, and a third is women. And many women enter into prostitution or sex work because they are initiated, so to speak, by some form of exposure to drugs. It's how they're manipulated. So that's a whole different area that is problematic and troubling. But here you are moving beyond the addiction level of substance abuse to new ideas, new modalities for serving the population at risk. Lori, would you like to introduce our next speaker?
Yeah, I would love to. Our next speaker is Spencer Cox. Spencer Cox is a geographer, and he does a lot of GIS modeling. And so, Spencer, take it away.
Yeah, hello everyone. It's great to be here today. As Dr. Post said, I am a geographer, geospatial analyst, but basically that means I like maps. I make a lot of maps, and I think that they're a good way to display data across space and time, thus this presentation. So first off, you'll maybe remember a chart like this from Dr. Post's presentation. I work underneath Dr. Post at Northwestern. And for this presentation, we're going to be focusing on the United States specifically. As well, all of our metrics are going to be death rate per 100,000 people. So trying to get some of the housekeeping things out of the way. We're starting our kind of journey through space and time, looking at drug overdose death rates in 1999, because that's where toxicology really became good enough to track all of this information accurately. And we're going to go through 2023. As Dr. Post mentioned, 2023 is where we have our last complete year of information, still waiting on 2024 data to finish up being dropped. And she talked a little bit more about why that is important. But as you can see, and Dr. Post mentioned, in this chart, we have all drug overdose deaths. So if you see DOD, that is drug overdose death rates. We have all of those, and then opioids specifically, and then below that, cocaine and methamphetamine. But if you're like me and you want to see something play out over space and time, then I have a series of maps for you all. A couple more housekeeping notes, I guess, on looking at the maps and trying to correctly interpret them so that we're on the same page as we're going through them. If you look in the top left corner, you'll see the year. So if at any point I'm flipping through maps and you are confused on what time we're looking at, look at the top left. At the bottom left, you'll see the legend, which will remain constant throughout all the map series we look at today. So first and foremost, we're starting in 1999. About 25 years ago now. And you'll see that most of the country at this county level is very few drug overdose deaths on a county per 100,000 person basis. if you remember the chart that Dr. Post showed earlier, where it broke down the Northeast, South, West, and Midwest, you'll see that those regions are displayed here in the darker black border, and then state have a very thin black border around them. So from 1999, our next time jump is to 2011. And during that time period, that's when the opioid crisis really started to take effect with its first wave of prescription opiates. You'll see a couple things as we go into 2011. I think the most important is a couple areas of focus that I want to kind of hone in on. I want you to keep an eye on the Northeast, specifically looking at Maine and Massachusetts and Vermont, that area. The next area of focus, I want you to look at the Western United States. If you just quickly look at the Eastern United States and the Western United States, you'll notice that the Eastern United States is populated by oddly shaped, very small counties with a big disparity in population size. And then in the Western United States, for the most part, it's these huge, massive counties that were broken up in straight lines. If you look at any of the Four Corners states, so that's like Wyoming or Colorado, New Mexico or Arizona, a lot of them are straight lines and broken up with very, very little population. So that means if someone does have a drug overdose death in those states, then that affects the rate much more than in one of these smaller counties. So the third place I want you to keep an eye on is right here in the Ohio River Valley. Now, I'm from Kentucky myself. I'm actually from right up here at the top of Kentucky, but my entire family has a history in Appalachia near West Virginia in southern Ohio. So I'm very connected to this region myself and keep a close eye on it. As we jump into 2014, this is an illustration of kind of the second wave that Dr. Post was talking about, where it's primarily heroin. You'll see across the board between 2011 right here and 2014, there's a very slight increase in the average drug overdose death rate across the nation. It went from 16 in 2011, so 16 drug overdose deaths per 100,000 people, to 18 in 2014. As we keep going on down the line, we'll hit 2017, and this is where fentanyl really peaks. You can see, again, our key regions. If we look at the Northeast, all of a sudden fentanyl becomes more and more of, or so the Northeast becomes more and more darker blue. The West Coast continues looking blue. But then really the Ohio River Valley, you look at southwestern Pennsylvania, you look at West Virginia, Kentucky, Ohio, all the way down, you'll see that is one of the main areas that it's going through. And then our final year that we're going to look at is 2022. And in 2022, the average drug overdose death rate across the country was 33, whereas back here in 2017, so we just went back in time a bit, it is 23 is the drug overdose death rate. So into 2022 again, this is the peak, as Dr. Post mentioned, and across the nation, we see a peak everywhere. But if we keep looking at our focus areas, the Northeast is specifically looking bad, especially these areas up here. The Ohio River Valley corridor is another place that you can see a lot of the darkest shade of blue. And then places in the West Coast that Dr. Post was mentioning that are kind of catching up now in drug overdose deaths, looking at Nevada and Utah and a few other states. Those are also increasing at this time period. We're going to break it down a little bit more into opiates specifically across the same time intervals. So if we start in 1999, we see that across the nation, most of the counties have relatively little drug overdose deaths. We move into 2011, we can see some of those same areas, Kentucky, Ohio, Indiana, those areas are really starting to get darker in their color gradient, which means that the rate of drug overdose deaths is increasing. And we continue to see that as we go into 2014, 2017, and 2022, where it starts to go down a little bit. We're going to now take a quick look at methamphetamines in the same order. Again, 1999, relatively little all across the board. Still an issue in certain areas, but not a pressing issue across the nation. We keep going to 2011, you start to see in some of those key areas that we've been talking about, but looking at the West Coast, looking at the Ohio River Valley Corridor and the Northeast, they're starting to increase. In 2014, we see another gradual increase. You can even pick out small counties that are starting to go up further and further in the color gradient. In 2017, I think this is one of the starkest contrasts. And then into 2022, some of those key areas really start to present themselves as problem areas. In 2022, as Dr. Post mentioned, that's really where polysubstance, so mixing opioids with other things, with stimulants, starts to really become a prevalent trend. But what does all this mean? Why did we put it on a map? Why do we map it across space and time? Of course, we know that drug overdose deaths are rising between this time period, but we also know that counties in the US experience those rises and falls differently. Just because Spencer County in Kentucky has a massive drug crisis going on doesn't mean that Sacramento County in California is experiencing that same issue. And understanding why counties are going through different counties, states, and regions are going through different trends is really important, understanding how we can react to those. Of course, as I just kind of mentioned, none of the drug overdose deaths in America are randomly distributed by geography, but instead, the crisis has moved across the nation in different ways. And so we can see, as Dr. Post mentioned, that the West Coast is now starting to pick up where some of the East Coast, South, and Midwest have started to decrease in drug overdose deaths. As far as plans to move forward, we're going to continue looking at this and mapping it out as we get more data, and continue to work in a spatial setting so that we can understand how time, space, and kind of trying to answer the 5 W's of why, when, what, who, and where. Thank you guys. I know that we're a little short on time, so I'll go ahead and conclude my presentation so that we have some time for questions for everyone. Thank you guys.
Thank you so much. I came from near the Ohio River Valley too, so I saw the changes in my face, so to speak, in southern Indiana. Thank you, Spencer Cox, for adding a new dimension to our subject of substance abuse. Do we have some questions, Sarah?
Yes, we do. So the first question that I have here is, will the slides be shared? So that was a question that came through one of the attendees, and I don't know if there's a way we can do that, but I just wanted to put that out there to see if that is something that we could make available.
I think we can probably convert our PowerPoints into PDFs because the barriers are so memory intensive to email them out, but you're welcome to share them.
If you send them to me too, I will put them as attachments on the WUNRN listserv. And I think that would reach an enormous audience. Thank you.
Okay, great. There's a question that came in about breaking the cycle. How can we address the multi-generational impact of substance abuse and create long-term solutions for affected families? So more of a multi-generational lens. Who would like to answer that question?
Jay would.
I mean, there's multiple things going on, right? So there's the generational trauma that happens as parents who use substances can often cause trauma for the children themselves. So addressing trauma at those points and sort of stopping that chain reaction is an important piece. So any of these treatment systems that can be developed that address so we call that trauma-informed care, but treatment systems that really acknowledge the trauma, particularly family trauma, and provide supports for individuals. So treating the trauma is probably the most important piece at every step of the way, and whether that's treating it as for children or treating it for adults that are recovering from their parents that are now engaging with their children in the same way, you have to break the cycle. The other piece is that these things aren't detached from the larger social order. And if you're in a community that is experiencing a refugee crisis, that's just going to be traumatic and that's going to be bad. And so doing anything to stop the trauma is a really critical part. So these larger social efforts that the UN and other entities are engaged in at reducing the harm, Lois was discussing human trafficking, particularly around women. Like being able to intercede at any of those steps to address those issues is going to address these intergenerational traumas. We also have tools for this. We have family support. We have wraparound care that treats the whole family as opposed to treating a child. So if you identify a child with an issue, it's probably true that that child is embedded in a family environment that has things that are going on that can also be addressed with forms of treatment. So making sure our treatment systems acknowledge families as a unit and not just individuals as a unit, which often isolates the problem in a way that makes it difficult to really address it. So I think in all of these, the answer is having a holistic, family-oriented, multi-generational perspective that can address these issues, both from a procedural approach to address any individual thing, traumatic events, sexual assaults, human trafficking, those kinds of things, but also providing systems of care that recognize the family as a unit.
Thank you very much. Yes. I'm also wondering about pregnant women and babies who are born addicted. Would someone like to make a few comments on that?
Go for it,
I
Jay.
know that doctors.
Treatments work. And, when it works, it's because, if women come forward and feel like they can engage with a healthcare provider in a non-stigmatized way, so you're using opiates, you discover that you're pregnant. At that moment, if you engage with a healthcare provider and you can get on methadone or buprenorphine, we have ways of making sure that pregnancy can be as positive as any pregnancy for any woman. And so there are treatments available for that, but it really requires the system to not criminally punish women, number one.
Exactly.
And number two, to provide adequate supports for, adequate supports in that recovery-oriented system of care. Medically, we know how to deal with newborns that are born addicted to opiates. Neonatal abstinence syndrome is a well-established, well-known thing. We have procedures for addressing it. The outcomes for those kids are fabulous when they engage with treatment.
Great.
Thank you very much.
And I would like to add on and also put another question out there too, is that, I talked a lot about drug overdose deaths, so did Marianne and Spencer. Jay talked about the hope that comes with the option of treatment. But it's also important when we think about that these are two different populations. So specifically, I'm looking just at those people who die from drug overdose deaths. And there are many people who die from drug overdose deaths who are not dependent. And many are early initiators or, one-time event. We don't know. We have some better indication as to how many of those there are, but for every one drug overdose death that where someone dies, there's 7 to 15 people who are saved. And the other thing is, if we take care or we get better at combating drug overdose deaths, by resuscitating people or whatever, doesn't necessarily make the problem go away. We need to make the problem go away. Then I wanted to kick it to Jay to also ask is, you talked a lot about great treatments for opioid use disorder, including methadone, buprenorphine, naltrexone, naloxone, all of those. And so can you talk about the forefront of other substances such as tranq and stimulants, cocaine, crack, methamphetamines, since we haven't made much progress, which is interesting because a lot of those are old problems with less options.
Yeah, I think your point is correct that opiates are the one we have the best treatment for. Alcohol use disorder, we have we underutilize alcohol-based pharmacological interventions, and we have some of those. But for the stimulants, cocaine and methamphetamine in particular, we're very early in that drug discovery process, and it's probably a lack of investment by the system, by pharmaceutical companies and governments in developing those drugs. So we are really reliant on psychosocial interventions. Contingency management is one that has a pretty strong evidence base. And so making sure that systems are using the best available treatment options for those is important. But we have more work to do on the pharmacological side.
Mm-hmm. I would agree. Women, at least in the Midwest, used to cross-medicate. So you could go to one doctor and get one form of opioid pain relief, then go to another and get a different meaning, like your regular family doctor, and then an OB/GYN. What's happened now is that there's a computerized record of who you were given a prescription for. And that way they help to address that. But it still is an issue of crossing alcohol and drugs or different kinds of drugs. Mm-hmm. Are there any other comments that you would like to make? I think this panel really is valued, and we hope to do it again in another way. I know Dr. Lori Post and I have known each other for quite a few years. She originally did some research on public will versus political will, and really almost all the social issues that are so significant and very much in today's world are related to those two factors. I really feel that the issue of shame, discrimination with women is so significant, because if a woman in the US is charged or accused of being dependent, her children may be taken away from her and put in a foster home that may also have problems. Mm-hmm. Or she may be sent to prison because she is a mule for trafficking drugs. Mm-hmm. If there are no more comments, I guess we will close. But really, you all have been brilliant and so significant that we are going to have our video available. And if you send to me or Dr. Lori your presentations, we will see that they get to an even more expansive audience. So thank you. Grazie mille. Merci beaucoup. Thank you for your time, your data, your comments, your insights, your realities.
Merci à vous.
Yes, thank you so much. I'll let you all know when the video will be ready. It'll be a YouTube link. We did have a lot of great feedback in the webinar chat. If you feel that you want to share your contact information at all, please type that in the chat. And thank you so very much for attending today. And Spencer, thank you for answering the question in the Q&A. Thank you.
Thank you so much.
Mm-hmm.